don't you think Britain's gotten weaker and weaker, weaker? Don't you think when you see their influence, their wealth, the immigration that they've opened up, the crime, they no longer are seen by the world the way they did 10 years ago, 40 years ago, 60 years ago? Like,
Yeah, yeah, you can take that back 100 years because that was the whole point of the pivot. When the British recognized that they were no longer a map of the United States, coming out of the Civil War, we weren't destroyed because we wanted to handle the British troops, the Confederacy, the slave system, and all of that. But we weren't destroyed after the Civil War. Lincoln, despite his assassination in 1865, had set into motion the revival of the American system of political economy. By the time we had the 1876 Centennial Exhibition, we were the wonder of the world in terms of what we were doing with industry and so on. But what did they do? They started assassinating our presidents. And then they started corrupting our institutions. So by the time of the turn of the 20th century, the British explicitly outlined people like Cecil Rhodes, Rhodes Scholarship, the British Roundtable, explicitly saying we have to bring the United States back under our way of being. So that for most of the, for all of, almost all of the 20th century, now, for a large part of the 20th century, we were the dumb giants to their policies. So they don't have to have a strong villain. In fact, the House of Lords just published an extremely important report where they reviewed the U.S.-British relationship, and they also reviewed it at Chatham, right? And a number of the lords were very, very clear that we have benefited by this system that we set up, but this system only exists through the United States interest. You say that? Yeah, that's the report, or that's the Chatham's forum, which was just last week. But throughout, they admit we couldn't enforce this system without the United States basically doing it for us. So they don't have to be strong. They just needed us going along. And especially with President Trump's second term, they did it. We're not going along. So, King Charles over Chris Charles, which I don't think
what do you think happened? Because the first term, the president seemed like he was trying to do things, but it wasn't fully creating momentum. What do you think happened on the break that he had for 4 years when Biden came in? I wonder what adjustments you think he made to his approach, because he was determined to get back in there. Because everybody was asking him, "Are you going to run again?" He said, "Yes." He says, "I've never had a more exciting job than this one. I have to get back in there." He really wanted to get back to become the president again. It wasn't like he was contemplating not doing it. His words. What changed with him? What adjustments do you think he made? Did he go from thinking who was the enemy in 2016 to realizing that's not really the enemy, this is the enemy? Because on the second term that he had, his sequencing has been very interesting. He first gets Panama Canal. No, he first gets Venezuela. Then he goes and finds a way for Panama's president to turn against China to say CK cannot have this control of these two ports. And then he goes and attacks Iran. And then what changed? What do you think changed? Did he figure out something? Do you think he realized who the enemy was on the second term versus the first term?
I think he always had a kind of general idea. I'm not going to venture too far in terms of what he knows, what he doesn't know, because I don't know what he knows and what he doesn't know. What I see is the effects of what he does, and I think one of the things that happened in the first term is, he was just hit across the face with how evil and how deep these institutional forces were. How much does he understand their origin? I have absolutely no idea. But I look at the way that, as you say, this second term has been completely different. And I think, once he recognized what COVID was, once he saw what happened on J6, he saw the steel, then of course you get the assassination attempt in Butler. But I think, he got a much deeper understanding of how evil what it is he was up against. How much, again, the history is there. I can't believe that somewhere in this administration, you don't have some very deep institutional knowledge of what you're up against. Because you don't make changes in the administration. I actually ran you don't revive the American system randomly. And I should reference the fact that Winston Greer, the created that, he went to Ghana. He gave an amazing speech. His place is ahead of the American system that nobody knows about. And he literally went through Alexander Hamilton, how the Americans had been the economic philosophy which guided this country in the 19th century and made it great. So there are people who know this kind of hidden history, which we're all supposed to forget about. So we all just sit there and react to the shadows of the wall. So, who has people using historical? I don't know. But somehow this combination of people is really extraordinary.
Yeah.
Especially when you have J.D. Vance, Scott Besson. I've been following administrations since 1976. I've never seen anything like this.
What do you mean by that?
In terms of confidence, coherence, singularity of purpose. One of the things you probably noticed, there's no leak. This is not a government which is where some faction is trying to, get factitious advantage by leaking this, that, the other thing.
You had a little bit of that with Michael Waltz, and you had a little bit of it with Joe Kent, and you had some
Well,
of those.
look, and there, guess how long they got,
So hello.
right? That this is a different animal. This is on point. They have a mission. They certainly
Hello.
understand this.
Hello.
They say that, they said that, they went to Davos, they said it. James.
Hello. Can you hear me okay?
Careers and policy of the American system. So, it's there. Um, and then you have people like Scott Besson who know from the inside how this British financial system works. He did work with George Soros, he did crash the British pound. So, he's got some skills. And, those skills are being used for us now for a change.
That makes sense. And by the way, if there's a guy that knows how to mess with the currency very well, is George Soros. So to be with him, I think he worked with him once for 9 years, second time for 5 years as his chief investment officer, or chief, I don't know what it was, but he was a heavyweight with Soros. So he had that experience. But to finish up with UK, when you see this chart here, this is from a paper that came from the Institute of Economic Affairs. When you look at this, it said what Americans perceive or UK to be in ranking of how wealthy UK is versus US for GDP per capita. And they said Americans believe UK would be right behind Jersey, okay, meaning New York first, California second, Washington third, Massachusetts, Texas, Jersey, then UK. Then you have everybody else, which actual ranking, UK would be 51st. So how much of their control that they have, the actual control and the actual wealth that they have is far apart, where America is just because you said something. You call him the dumb giant, right? The UK sees America as the dumb giant. Is this dumb giant becoming so giant that you can no longer control it?
Yeah, and well, it's also becoming way less dumb. I mean, that's the point. You know, when you rediscover the American system and the power that that actually gives you to be economically sovereign, you know, look at the question of energy. Well, you know, what is one of the premier policies of President Trump? Energy independence, which means you're no longer at the mercy of the Strait of Hormuz. You're, unfortunately, we're still at the mercy of Brent futures pricing, but I think that may recalibrate at some point, not too far distant future. But you create independence in energy. So you're not reliant on their markets where there's strategic choke points, where there are loads of London insurance cut off, and so on. And everything this administration's done, a lot of it quiet. You know, where you look at something seemingly boring, like the recent executive orders that the president promulgated on April 20th, where he invoked the Defense Production Act for a whole gamut of aspects of our energy sector, not just energy production, but generation and transmission, where we're incredibly vulnerable. We don't build transformers in the United States. And if we had to order one from South Korea, it would take 2 years. So let's say we had a bunch of transformer accidents. The lights go out for years. And the president said, no, you know, this doesn't work. And in his order, he says the market is not seeing to our national defense. So we have to step in. And, you know, there's all sorts of government financing institutions under the Defense Production Act, in the Energy Department, things like the Export Import Bank, I think it's one called the International Development Finance Corporation. But these government corporations, where this administration is saying, hey, Wall Street has not, and the free market, has not seen what they we are vulnerable to all the various Republican discoveries. Well, you know, we have to use the full array of government power to make sure that we're producing the basic things we need as a nation. One of those things is tariffs. And another of those things is how do you actually get credit into these sectors? If JP Morgan Chase would rather speculate than invest in some vital industrial area, how are you going to get the money in there? Will you use these government financing agents to make sure that the credit goes to people who want to produce here in the United States? J.D. Vance described it in terms of our strategic mineral weaknesses. He said, look, companies would come in and want to invest in a processing facility here in the United States. And they go through the onerous regulatory policies, and they put a lot of money into this. They're just about ready to get going. And China would come in and undercut the price and wipe them out and they go bankrupt. So we didn't have anything in the United States. He said, that's crazy. He said, so we're going to create new kinds of mechanisms where the producers are protected and they can produce. So what I mean by we're not dumb anymore. You know, dumb is blindly following the British free trade system. You know, blindly believing some mystical, invisible hand is going to make it all work out. No, the invisible hand is taking your pocket to feed the city of London. And Donald Trump isn't playing that game anymore. And that's the problem that the British have right now.
And how much of that do we see when you all of a sudden saw Lloyd's of London pulling out? Was that a mistake on their end?
I think it was a mistake on their end. I don't think they expected this administration to do what it did, which is to step in and say, okay, you're not going to do it. England. So we essentially just broke a 300-year monopoly on shipping insurance by them pulling out. Because, of course, that's the first time they had ever canceled insurance. With all the other conflicts in the last 30, 40, 50 years, you have a conflict in the region, they jacked prices up. That was their business model. You know, they did quite well from it. They never canceled. And the fact that they canceled was their way of saying, we do not agree with Donald Trump trying to end this game. So we're going to call this bluff, we're going to cancel, and have counter bluff and say, go ahead, please, I did.
How important was it? The average person didn't pay attention too much to that when that happened. In the power structure, how important was that move? And what do you think behind closed doors? UK sitting there saying, wait a minute, what did he say? He said he's getting short? Yes. Oh, shit. What do you think their reaction was to this?
No, I think you hit the nail on the head. They did not expect the president to do any of these kinds of things, which is why they've been so flat-footed in terms of all of their responses right now. And it's out in the open. I mean, suddenly the country, which was our oldest and dearest ally, which I was really scared of, people would literally say, Britain is our oldest and dearest ally. And say, excuse me, do you remember the American Revolution? Do you remember the War of 1812? They're not our oldest ally. Right, but people were sort of in the scary tale and the soap opera of the royal family and all the rest of that. And I think this experience where in essence the British are outing themselves by responding to a president who will openly not play their game. So I think
who came from the UK to the White House and gave an invitation to the president that's never happened before. We've never had before. And his reaction was very complimentary. I don't know if you remember this or not. This was about a year ago, maybe 14 months ago. He got an invitation to do something that never in the history of America has that happened. Do you remember that?
Yeah, sort of about as much as you do in terms of, I don't remember the specifics.
Yeah, but it seemed like it was a big deal to the president. It seemed like the president was very honored by it, and he was very, taken by it. It's not too many times you see him going through it where you kind of see, oh, this is interesting. This has never happened before. But at the same time, I know the vibe he gives me is he doesn't want to be the man where anybody thinks they can control. He'll deal with everybody. He'll do the team of rivals. And a lot of people will say, well, he's owned by this, he's owned by that. They control him. They tell him what to do, and he does it. Um, I don't know if I fully buy into the fact that he's controlled by anybody. I think he's his own man in making the decisions. You know, this Ultimate by 10 and Beauty podcast started with a phone me and Mario. That's it. And it grew today to 15 million subscribers almost and 164 full-time employees. And that relationship where you watching us and supporting us wouldn't happen without you. But did you know 51% of you that watch the content are not subscribed to the channel? And it would mean the world to us if you could press that subscribe button and notification like it allows us to grow, hire more, do bigger interviews, have a bigger team, and deliver a better product. If you haven't yet, if you don't mind, press that subscribe button. It would mean the world to us. If you enjoyed this video, you want to watch more videos like this,
And you've been watching rebounding videos thinking, that looks fun, but there's no way I can do all those fancy moves. I have really good news for you. For 30 days, I did nothing but the health ones. No jumping, no choreography. My feet barely left the mat. And I'm going to tell you exactly what happens to my body because of the psychopatic benefits of the health downs. And I was curious. So I committed 30 days, 10 to 15 minutes a day, just to health counts. No fancy moves. Let's see what happens. So before I get into the real results, let me explain exactly what the health bounce do. Because if you're new to rebounding, you might not know. The health bounce is when you stand on the rebounder with your feet about hip width apart. And you just gently push down into the mat and let it spring you back up. Your feet either stays on the mat the whole time or they lift just slightly off the surface. There's no impact on your chest. You're not pounding. You're just trying to not get air and feel the rhythm of the rebound. And the magic is here, even though it looks super easy, every cell in your body is experiencing that up and down motion. That's what activates your lymphatic system. That's what gets your circulation moving, and that's what helps with inflammation and fluid retention. Sometimes I get my arms loose. Sometimes I'd swing them gently. Sometimes I'd put my hands on my hips. I wasn't doing anything crazy. I put on a podcast or music and I just danced. And you know what? It was actually kind of meditative. There were days I'd get on the rebounder, stressed out from work, and after 10 minutes of just bouncing, I'd feel completely different. So, week one, I'm not going to lie, first few days felt almost too easy. Should I be doing more? Should I add some moves? But I stuck with the plan, help bounce only. And within about 3 days, I started noticing something. I woke up less puffy. My face wasn't as swollen as it usually is in the morning. And honestly, I was shocked because I hadn't changed anything else. Same diet, same schedule. Only difference was a gentle bouncing every morning. By the end of week one, my legs actually felt lighter. I can't even explain it, but you know that heavy feeling you get in your legs by the end of the day, that was just gone. And I had more energy. I wasn't dragging by 2 p.m. Now, I will say the health mouse works muscles I didn't expect. My calves were a little sore, and my core felt engaged in a way that it doesn't when I'm just walking. But it wasn't a bad sore. It was that, oh, something's actually working here. And here's the thing, because it was so gentle, I actually looked forward to it. There was no dread. There was no, oh, I have to get my work on done. I get on, bounce for 10 minutes and feel good. And that's huge when you're trying to stay consistent. By week two, things started getting really interesting. My stomach was flat. Not like a little bit flatter, but noticeably flat. And I wasn't doing any core work. I wasn't doing crunches and planks. I was just bouncing. And the reason is that the health bounce engages those deep stabilizing muscles. The core has to work to keep you balanced and stable, even though it doesn't feel like we're working. It's sneaky in the best way. I also noticed that my digestion improved. I always had some bloating issues, especially after meals. I ate a lot of protein, and that just kind of went away. I think the lymphatic movements, everything was flowing better. Not 3 pounds, 3 inches. And that tells me it was inflammation and fluid retention, not muscle. Staying without putting stress on any. If you're intimidated by all the bouncing, rebounding videos, I think more women with joints, rebounder, and just gently bounce for 5 or 10 minutes a day.
Swear lips. It's real. Look how hideous it is. Swear lips. Sir, my guys don't wear black berets.
Oh, is that right?
Recognize this? You call it astropage. You star here. Star, bad. Yeah. Same. Why are you all? What happened? Sorry. Why did it happen? three of us and shoot out on the way here. We should also meet. Recognize this? Pull an astro page. Stars. This was page. Star. Bad. You know. Same. Why are you? Oh.
Hey, can you hear me okay?
There were three of us and shoot out on the way here. You should
Can you hear me okay? Awesome. Hey, no back. There's a little bit of delay here, so just bear with me.
Same. Why are you?
Awesome. Hey, no back. There's a little bit of delay here, so just bear with me.
Yeah. Sorry. I was Oh, there were three of us and
Wayne or Jan, can you hear me?
recognize this? We call it astro page. Star eater.
Wayne or Jan, can you hear me?
Astro page. Star. Bad. Yeah. Same.
Awesome. Okay, guys. Well, let's start with getting logged in. So, if you, as you recall, when you first started the class, you had to go to this website to set up an account, and I sent you guys an email this week to, um, in reference to being able to log into it. I don't know if you got it or not. Ah, there's Wayne. This website to set up an account, and I sent you out an email this week reference to reference to being able to log into it. I don't know if you got it or not. Ah, there's Wayne. And now, of course, it's not working right now. But anyway, all right. So, but this is the site we need you to log into. We need you to log into uh, mygymsys.org. Let me just start over here. Mygymsys. You'll see it asks you for organization ID. Type in Georgia. Anyway, all right, so this is the site we need you to log into. And then with that same username and password, what you're going to do is you're going to log in with your username and password for my gym system that you already had. Ask you for organization ID. Type in Georgia. All right. So first, let's start with can you log in? So that's what I want you to do. I want you to log into mygymsys.org/elite organization Georgia. I want you to log in there, and when you get logged in, I want you to let me know that you got logged in. So this is usually the part that takes the longest amount of time is just getting logged in. So please do that. You bet. It's the same username and password as you use for mygymsys.org/LMS, which is what you had to set up. You had to set up an account on there when you first started the class. And everybody's in there. You're already in there. If you can't log in, I can actually help you out. I can actually help you get logged in. Pretty good. No backs in. Okay, so Brad skewed not letting him log in. Okay, hold on. Okay, Ayers, cool. Thank you. Let me see if I can help Brad Askew. All right, so Brad Askew, it's the login username and password that you use to log into this website. Why is it not working on here? That's so weird, ridiculous. That's- Remember that when you logged into that one, Bradescu? MyGymsys.org/LMS. It's that. It says my word is wrong, the password. All right. All right. Okay. All right. So just give me a second, guys. I'm going to reach out to you individually through an email, okay? Just give me 1 second. I'm going to send you a username and password to it, but I don't want to put it through here, okay? Hey guys, Sherman and Bradescu, I've already got you guys. I sent you guys your username and password. All right, Jade. Jade's having a lot of problems logging. All right, hold on, Jade. Oh, you're in. Okay, Jade's in. Okay, Wayne and Bradescu, let me know when you're in. Let's see, Novak is logged in. Jade is in. Ayers is in. Okay, Wayne's in. All right, now we're just waiting for Bradescu. Anybody else? Is anybody else having any problems logging in? Oh, okay, no problem. All right, try it now, Bradescu. Right, looks like we're all in. Okay, everybody is in. Now let's log in. You're gonna get a little message that looks like this. Okay, something like that. Just click yes, we get it. Okay. All right, so now we have this announcement page. All right. What you're going to do is you're going to go up here to incidents. You're going to see it's going to drop down, and then you're going to click on Georgia EMS 3.5 form. Okay. All right. So now everybody should be looking at this page. So let me know if you're looking at this specific page. Okay. Just let me know when you're seeing that. We're all looking at the same thing. Okay. Well. Okay. Good deal. All right. Is anybody not looking at this page before we continue? Okay. All right, we're gonna get started. All right, just do what I do, okay? Don't do anything. Don't ad lib anything. Don't just do exactly what I do, okay? We're gonna do this a couple of times so you understand how this process works. Okay. Okay. If you just did exactly what I just did, you will see that. You see it where it says at the bottom, it says 100 validation right here. It says one validation 100. I'm just trying to give you an idea of what this is all about. So, like, the easiest way to do this is just jump in here and try to do one, even though you may not 100% understand what this whole process is about. Trust me, by the time you get out of here today, you'll understand this a little bit better. Okay, so when you get to the point where you're there, let me know. Damn, you guys are good. Jeez, you guys really follow instructions well. Yours is good, Novak. Okay, okay. Well, look, if you're having a hard time following along, just hit the save button. That way I can see it and I can help you fix it. Yes. I'm going to do another one. I'm just going to start over again and do another one so you can see what we're doing here. Okay. The objective is that you're going to have five of these. So basically, your PCR is done. No, Brad Askew is done. Brad Askew and Novak are done with the first one. Okay, so now we're gonna. The last thing we're gonna do here is finish the incident. All right, here we go again. Start here. Incident number. Cancel. Cancel. Leave this blank right here. Unit notified by dispatch. Leave that one blank because there's a reason for that. You'll see that in a minute. It's pretty specific reasons dealing with this particular software. Gonna add a crew member. I'll always like to add this guy, Aimer, and it always puts on, he does everything, so he's good. And then hit next. Dispatch reason, abdominal pain, and hit next. All right, unit info, we are Med 1. We are a BLS equipped ground ambulance. We are the first unit on scene. We were dispatched through 911, but we were dispatched as a non-emergent. The number of patients is very important that you put none. Otherwise, the validation in this system will fire up, and it'll want to know like a bunch more information. All right, and then when we got on scene, we found that there was no patient at scene. Crew disposition is back in service, no care support required. Incident location type is a home or residence. Incident street address is 123 Elm Street. The postal code is the one in Chamblee. So I'll type it in there. Yeah, Cambodia. And then we click on next. Next. And then we look at the times. And this is really important. The times can get really screwed up really quick. Um, the times can get screwed up really quickly. And so, Dan, let me show you with the error page, your error message that you got on the crew info page. All right. So, um, you start up here at the top, at the very top. If the times are not in sequence, it's going to flag it. All right, so you put on there update crew, and I said cancel, and it didn't really change, and so it gave you this little error on the side there. So let's look at what we did here, the dispatch. So basically, it wants a lower acuity, but crew info. Let's go look at this crew info again. So basically, I'm going to add another crew member. You just need one crew member here. So not only do you have to add the crew member, but you also have to give them a response role. Hit save. All right, who's got questions? All right. Okay. Wayne, I'm going to log in as you and let's look at Wayne's report, okay, and see what he did wrong, okay? So I'm going to take over for you, Wayne. And you guys are handling this really well, by the way, so I appreciate that. All right, I'm logged in as Wayne, okay? All right, so now let's just start at the top here, figure out what happened. All right, so crew info, dispatch information. All right, so dispatch reason is abdominal pain problems. Lower acuity. We know it's going to ask later, so I'll just I'll go ahead and select it. Unit info is Med 1. BLS, unit info is a BLS ground transport. You were the first unit on scene. Response type requested is a 911 response. Response mode to the scene is not emergent. Number of patients. Important to select none at this point for the purposes of what we're doing right now. Okay. And then we had no patient found. Crew disposition. You scroll down to back in service, no care provided. Incident location type is a private residence. The address is always 123 Elm Street. And then I like to use Chambly's zip code. Figure something weird's going to happen. It's going to happen in Chambly. All right, now the times. I start at the top. Boom, boom. Just do the ones that are loud. So start boom, boom, boom. Update crew, cancel, boom. See if they're not in order, it's going to get flagged. You guys have all used really super picky software before, and that's Wayne's. All right, Wayne's is all done. All right, so now let's go and try this again. I want to see you guys do this like a couple of times. All right. We're trying to just to understand the process. Yes, you need to click finish. Yeah, you do. Okay, everybody's doing them. Fantastic. You need to have 199 to 100% validity. No, just keep doing the cancel one. I'll go log in as you. We'll find out. We'll look at yours. Looks like you got a time. Looks like your response times are screwed up. See if these aren't in sequence. it will flag it. Look at that, 100%. Okay, so what's going on? Wayne and Ayers. Are you guys working on your second one yet? We can kind of see what's going on, but not 100%. I'm just checking in. I haven't seen one on here from Jade. Can you do another one? Can you bang out another one? Hey, Wayne, why don't you give me a call? Yeah, what happened to Jade? Oh, there she is. All right, Jade's on. Jade's on point. All right, so everybody's got one done. All right, Ayers has got two. I see one from Jade. Wayne is confused. Give me a call, Wayne. Oh, okay, so once you get finished, Jade, is you click on. Let me show you. Um, so you go on here. You finish this up. You hit save. Okay. You go down here to menu. You click finish incident, and you hit close, and you just go back up here to the top of the page and start another incident. Through. Hey, all right. So you are you able to follow along with what we're doing online? Okay. All right. Well, cool. Well, like I said, I'm trying to get you to understand the process here. There's actually a wider story here, but you kind of need to understand how fucking unforgiving the software kind of is. So yeah, it's really not. It's not. It's. I actually asked the state office if they would like, maybe cut off um, cut off the like all the validation stuff like that, But they were like, yeah, yeah, so yeah. So anyway, yeah, just but anyway, do that and yeah, just keep popping out. I just want y'all to do four of those, and we're gonna do. Then I'm gonna kind of make this more productive here. You just you need an introduction to this. The only way to do it is just to get on there and see how fucked up the software is. So yeah, okay, cool, okay, awesome. Well, let me know, or so I'll just keep them rolling. Yes, sir. Thank you. All right, bye bye. Okay, I'm still working on this. We're still on this. Looks like so. I'm looking right now. I'm just looking for you guys to um do four each of this exact thing. Copy and paste four each. Okay, and then we're gonna do one. Then I'm gonna show you. I'm gonna give you some scenarios, and we're gonna talk about how you might want how you might be able to um how you might be able to like what exactly is this doing here? Why are we doing this? I can make this more productive. Just give me a chance. Anyway, we're making very good progress here. All right. So when you get done, just let me know. Hey, Jordan's done. I know, Bredescu's done. Awesome. Hey, Jade, how's it going with it on your end? Yep, hold on, get a phone call. Jerry Cruz here. Okay, cool. I'm watching. I'm clear. Yeah. Okay. Okay. All right. Cool. Yeah, just skip that part. You're gonna go back and do the times later. Yeah, that's right. Let's see. You want me to do? You want me to do one again? That help? Okay. Yeah. All right. No problem. Yeah, that's primarily what you're doing. Okay. Well, just see how far you get with it, and then I can fix it. Okay. Okay. All right. Cool. All right. See you. Hello, Jay. Hey, how you doing? Hey, are you lost in the shuffle on there? Okay. Okay, I'll just check it on you. I hadn't seen you. I hadn't seen a whole lot of progress on there. I was just making sure you were still with us. Okay, cool. Okay, all right, cool. All right, no problem. All right. Okay, so three of y'all are done with this well already. Why don't y'all take a break? Take like about a 15-minute break so the others can finish. So we got a couple more to do. Then we're gonna do the last one together, and then I'm gonna give you an assignment to take home with you. All right, I'll fix it. All right, hold on. Just why don't you save it? Start another one. I'll fix it. Okay. Looks like you did. You figured it out, Wayne. Let me see if I can help Jade out. Uh, you just had to add this one time. Let's see. Oh, boom, boom, boom. If the times aren't in sequence, this thing is not gonna do. It's not. It's gonna be angry, and you wouldn't like it when it's angry. All right. Why don't y'all work on your next one, number three? Okay. Awesome, Wayne. Awesome. All right, everybody's done. All right, so why don't y'all take a minute and go to the bathroom or whatever, and then we'll do the last one together. I'm just gonna take a little bit of explanation here real quick. So I want to make sure everybody's back. So let's everybody. Can we all be back on game at 11:20? We'll do the last one together. Okay? It's working out really good. Okay, is everybody back? Okay, Novak is back. All right, Jade and Ayers, you back? Jade's here. All right, and Ayers. Awesome. All right. All right. So now that you can see what the patient care report system is like. All right. So now it's kind of now I want to give you a little bit of an explanation behind it and why we have it this way. And probably the easiest way to do that is to take something that you kind of understand and basically apply it to a patient care report. All right. So the first thing is I'm going to show you a little video that I made. There's no sound in the video. I'm just going to kind of narrate it. So it's an ambulance service, and they're all the ambulances are sitting around doing nothing, and a call is fixing to come out. This is AI generated. It's definitely I have a long way to go with AI. Okay, they're checking off their ambulance. He's got some kind of weird thing with tape. She also has a weird thing with tape. They get dispatched to a call with a radio that looks like it was made in China, and they're en route to the call. Apparently, they're going to a different ambulance. I don't know. It doesn't make any sense. All right, so they are going to get into the ambulance. They're reporting back to the dispatcher that they're en route to the call. The ambulance is now cruising through traffic. Looks like Toronto. I feel like AI's world is Canada. Obviously, AI must like Canada. And this in the back of the truck, he's actually doing more. He's actually looking at doing more stalking of the ambulance while it's en route to the call. It's extremely efficient. All right, now they're backed into the ambulance. They backed the ambulance into the driveway, and this lady said the lady has met them at the door, and obviously she has some abdominal pain. So now they're going to go inside the house, and they're going to have a conversation. And he's wearing a different uniform now. This is great. And now she's asking. Now she's taking blood pressure. And I don't know what. Looks like she's actively bleeding. Seems a little bit uh, inappropriate touching here at this point. It made me uncomfortable, so I left it in there. You know, they load her on an actual hospital bed in her living room, which is really interesting. Oh yeah, you see the two guys there. Look, it's the same. It's a clone, and somehow they've parked an ambulance inside of the hospital. Really happy about the job they did. All right, good room. Okay, so anyway, uh, so there you go. So that's the video that we just watched. All right, so let's talk about this for a second. All right, um, so all right, so what exactly what's the story? Obviously, how do we describe how do we take the how do we learn? So what's the story that's being taught that's being said here? So was there a was there a scene size up? Was there a primary survey? Was there a follow-up assessment? And what type of assessment was it? Think about that. So like what exactly happened? So yeah, we just had like a fun call and there's AIs doing weird things with cloning people and putting ambulances and ERs and things. But at the end of the day, what exactly isn't it the same story that we talked about in class over and over again? You guys with me? Are you hearing this? Yes, I'm talking. Can anybody else hear me? Can you guys hear me? Yeah, it is. I know. I know. I know it's laggy. Okay. So yeah, that's correct. So I just wanted you guys to understand that that's what we were talking about. All right. So now we go back to so now we go back to this. You guys already understand this, but I don't. Based off the language of the Chinese menu. All right. So let's just take a look at. So we did a scene size up. We did a primary survey, and then we did a focus tissue and physical exam, and then we transported to the hospital. See, this is exactly what we did in class, and that's exactly what was called for. Then now we have to write it up. Okay, so this is what we're going to do. All right, so the first thing we're going to do is we're going to go back and we're going to start up another patient care report. And you guys just do what I do. You don't have to make this up. When we get to the narrative, I'll take a minute and show you what I'm doing. We're just going to do what we just did a minute ago, except now we're going to make this a patient transport scenario. Okay. So we're going to go here. We're going to, um, start a new patient care report. This thing's not working right. I just had to want me to log back in. Okay, so we're logging in. We're making a new patient care report. So we're going to start at the top. So incident number is, we're going to call this transport. Transport. Leave the time blank like we did before. Now we're going to add a crew member. I like to add Aimer. He's already in there. He's got all these pre-assigned roles. Okay. And then dispatch reason is going to be abdominal pain problems. And I'm going to say this was, well, actually, we went lights and sirens, so it was emergent. Let's talk about EMD. So, what exactly is EMD? EMD is a kind of a technique that's used by dispatchers to sort of pre-screen the ambulance call. You guys, that work for, uh, you know, private ambulance service, you're not using stuff like this. You just go to a call, and that's kind of the end of it. But imagine, if you will, you worked in a very busy ambulance service in a very busy part of town. uh, you know, what emergency medical dispatch can do is it can say it can determine that a call does not require emergent response. Um, it doesn't. It could tell you to send a BLS ambulance over an ALS ambulance. There's a lot of things it can do to make things a lot easier. A lot of places, believe it or not, have EMD trained dispatchers, but they actually don't really use them because they, like, imagine, if you will, like, what would the public say if an ambulance had a 1 hour response time consistently? I mean, they don't really like it too much, and so they need. So a lot of times the EMD system is not actually used to 100% of its ability because of the lack of fortitude on behalf of the people that run the ambulance service, which is pretty common. These people are pretty gutless when it comes to dealing with the general public. But anyway, that's what EMD is. So let's just say that EMD was not performed, and we move on. But if the EMD had been performed, you would have been given a card number, and then they would have even and then the type of dispatch delay would have been recorded. All right, unit call sign is Med 1, like it's been. All right, we're a BLS equipped ground transport, and we're going to be the first unit on scene. Okay. Type of service requested is 911 to the scene. It was immediate. There was no delay. Response mode to the scene was emergent. Now look, let's look at some other elements on here. Additional response mode indicators. So you can actually change, like, it was initially lights and sirens, but was downgraded, or initial no lights and sirens and upgraded to lights. I've actually, I mean, these are all things that are pretty common if you use EMD. We used EMD pretty religiously years ago, and so you'd get sent to a call with no lights and sirens, but then an update would happen, and you would upgrade yourself to lights and sirens because you felt like you probably just needed to get there. A lot of times a call would come out, and then it would be they would want you to continue to the scene, but no lights and sirens, so you can be downgraded. Um, Again, I don't know how much of that's happening because it seems like people are waiting so long for ambulances that they're not going to downgrade you. It's pretty much that ship has sailed. All right, so the next is number of patients, or so you move on to next number of patients. We have a single patient. So now you see the rest of the PCR is kind of opened up. We made patient contact, and this time we the patient was evaluated and and care provided. The crew disposition this time is going to be initiated and continued primary care. Transport disposition, transport by this unit is the most common. You move down to the next one. Incident location type is a uh, private residence. The call address is 123 Elm Street. I'm going to type our zip code in here. No scene delay. All right, so the response times we have to kind of leave the response times. Probably the best way to do the response times is just to get it right up to where we made patient contact. So we're gonna go boom, boom, boom. We're just gonna add the call, add the everything until we make patient contact. So we're en route. We're arrived at the scene. Okay, now we haven't arrived at the patient. We're gonna continue this later. Okay. All right, so let's go back to the incident here and look at and square away some of these boxes here. So it says that we need to add something here. Oh yeah, final acute patient acuity. I would call that non-acute routine. Level of care provided was BLS. Okay. We're going to come back to the response times. We'll go back to the crew information. Apparently, it wants you to add another patient, another crew member. So let's add our good friend Ricky Abrams. And we hit OK. All right, so now we have satisfied the incident. Now let's go into patient information. Now, let me just tell you something about patient information. All right, for the most part, most of the calls that you're going to run, I mean, private ambulance, 911 doesn't matter. Um, you're going to be running these calls on the same people every single time. Like it's no shit. You're going to see that the you're going to see that such an unbelievable number of the same people over and over again. And so it behooves you to use the find repeat patient button here. And so this one particularly one was turned off for the agency. They don't let us use this for training purposes, but there's since I would say most of your patients are exactly the same patients, you've been going to the same one. There's no need to actually put all the stuff in there. What it's going to do is it's going to import the patient's name, billing information, medical history, and anything else that is saved specific to that patient, and import it into your document. That's going to save you a tremendous amount of time. My guess is that most people don't. I mean, in my time when this was out, this is none of this is new for me. This is pretty much had been using this for many years. Um, my opinion is that most people won't use the repeat patient, and they will probably just pretend like it's the same, like we're starting off at zero every single time, which is, I don't know. I was kind of unwilling to just uh, participate in this fantasy after, I don't know, so many years on the ambulance. Just got to the point where it's like yeah, like they're not the same people. I get it, you know. So all right, so but we're gonna put her name in there, and so we're gonna call her Doe. Last name is Doe. First name is Jane. Date of birth is this one's a little tough. Like, so one. Actually, you can just type it in. It's easier just to type it in there. 01 slash yeah 01 1971. Okay, so she's 55 years old. Okay, sex is a female. Race is white. Okay, the patient's address is the same as the incident. Boom. So that knocks a lot of the stuff. There's a lot of these little features on here that allow you to uh, oh yeah. So that allows you to just sort of like shortcut the stuff. All right. So we put got the numbers in there. Okay, and then we don't have there's no this is the same patient, so there's no guardian information. This would be this you'd fill this page out if you were dealing with like a minor, all right, or a child. All right, so disease related stuff, unknown. These are some very specific questions. It's asking about screening for COVID. Um, all right, so now we're going to go into the surgical history. So let's say that when we talked to her, we found out that she had um, high blood pressure. Okay, boom. And let's say that she said that she was a diabetic. Let's see, IDDM. There we go. So she is a type 2 diabetic. Okay. All right. And then she doesn't have any other history. Okay. Alcohol and drugs say that there was no evidence to suspect that. So uh, none reported usually blocks that out. Possible pregnancy. I would say I would say yes. Let's see. How about uh possible unconfirmed. Boom. Okay, medications. All right, let's see that she takes um lisinopril for her high blood pressure, and she takes um a drug called glyburide for her diabetes. And we're gonna so it's not enough just to type the medication in there. We also got to put the dose. So let's say that the dose here is um 10 milligrams, and then glyburide. Let's see, I believe that was like 25 milligrams if I remember right. I don't. I could be wrong. Okay, we'll go next. All right. medication allergies. Let's say she's allergic to, um, let's say she's allergic to IV contrast dye. And how would we know that? Because she's allergic to iodine. Immunizations, don't worry about it. All right, so patient complaints. All right, so the barriers to patient care, we're going to say there was none. Okay, patient complaints, we're going to make the complaint abdominal pain. Let's say that it's been going on for 2 hours. What did that just happen here? 2 hours. Okay. Primary symptom is abdominal pain, acute pain. Uh, it's acute pain, but it's not due to trauma. Illness unspecified. Abdominal tenderness. Tenderness means when you touch something, it hurts. If you don't know what tender means. Okay. Provider's impression is pain. Let's see if we got abdominal pain in here somewhere. Pain. Acute abdomen. Boom. All right. Provider secondary impression. I'm going to say none noted. In initial patient acuity, I'm going to say is non-acute routine. I mean, I guess that's going to depend on your definition of what you think is like critical. Like I find that people in cardiac arrest are not breathing. That's critical. I find that people who can talk to me, that's routine. They didn't have to call an ambulance. They could have called. Uh, they could have went to their doctor. They could have gone to primary care or something like that. Okay. Cardiac arrest. No. Possible injury. No. Possible stroke. No. We didn't do a 12 lead. She doesn't have any pregnancy history. All right, now we're going to add some vital signs. All right, we got so every time, every call requires one full set of vital signs. Just as it's just not going to accept your patient care report without something on there. Okay, so and yeah, you can put the current time in there, and then obtain this prior to unit's care. No, and then we just move on down to we didn't do an ECG. We auscultated the patient's blood pressure. The patient's systolic blood pressure is 140 over 60. Okay. And it calculates this thing called a mean arterial pressure, which is pretty good. I never really like, which is a pretty cool idea. It's used a lot in hospitals. They say that mean arterial pressure is really more of a better reflection of a patient's cardiovascular, status than anything else. But whatever. All right. So heart rate is 100. All right. Method of heart rate measurement. We palpated it. Pulse oximetry is 98%. Respiratory rate is 12. Respiratory effort was normal. So obviously, if she has normal respiratory effort, was it going to be required that we give the patient any oxygen? No, it wasn't. Unnecessary. You don't have to do that. Blood glucose level. You should, blood sugar, we're going to type in a number. So we're going to say it's 160. So we don't think that her problem is related to her blood sugar. Her Glasgow Coma scale. Now, we never really talked about this in class, but this comes up a lot on patient care reports, and the main reason why it comes up so much on patient care reports is because um, um, patients with head injuries patients with who go into trauma centers that have head injuries. Um, a Glasgow Coma scale is kind of the the idea the way that hospitals look at patients, and they give it a number. So it's a 3 to 15 scale. Obviously she's talking to us and she's walking around and she's alert and she's oriented, so we're going to give her a 15. But you can just look at this thing and go Glasgow Coma scale, opens the eyes. Glasgow Coma scale verbal, she is oriented, obeys commands. They were also giving you some additional parameters. If the patient was less than 2 years old, there's like a pediatric Glasgow Coma scale. Personally, I find that the Glasgow Coma scale is overall useless for us. We don't really sit around and talk about the Glasgow Coma scale, and it's not that useful for us, but it is useful for hospitals. So we put this on a patient care report. Um, so yeah, when someone says, "Oh, patient has a GCS of 15," that's a lot easier than saying the patient was conscious, alert, and oriented to time, place, and date. Saying 15 is a GCS of 15 is a lot more efficient. So I kind of relate to it. And since we are transporting the patient to the hospital, it doesn't have to 100% be useful for us. It can be just useful for them because they're one of the customers. All right. So Glasgow Coma Score qualifier, initial GCS has legitimate values without interventions. Level of consciousness was alert. We talked about this in class, and I say that there's alert and not alert. But on a patient care report, you do have to specify. So there's alert, then there's verbal, painful, and unresponsive. And as you'll recall from the class, for patients who were verbally responsive, painful, or unresponsive required their airway assessed. And if were having problems breathing, you were going to have to bag them. Okay, that just to bring it back, bring it full circle. Okay, so it gives you a revised trauma score, which is a score that's based off of which is a score that's based off the Glasgow Coma score. We don't use it in Georgia, um, and there's a lot of states that use GCS and revised trauma score to get a patient admitted into a trauma center. Um, the We don't really do that here in Georgia. It's not that we don't do that. I mean, can you imagine like if you're gonna in Georgia like throwing a math problem? Like you already got an emergency call, and now like we got to add a, a math problem to get them to go to the trauma center. That seems a little ridiculous. It's not very user friendly, but not every trauma system is as nice as what we have here. Okay, we didn't do any labs, physical exam. So we would estimate her to be, I don't know, 120 pounds. Okay. Uh, all right. The complaint. So these are neonatal situation. These are questions associated with neonatal scenarios. We didn't have a home delivery or anything like that. Okay. So patient complaint is. Hold on a second. No. Okay. Barriers to patient care. No noted. Time of symptom onset was. Let's see. We can start now and go move it back like 2 hours. You can actually just back it down. See, with boom, boom, like that. So you can start with the current time, and then you can move it back a couple hours just by clicking these little left plus and minus buttons. Patient complaints. We already did all that. Okay, moving right along. All right, next. Okay. All right, so now we're going to get down to I like to save the narrative for last. Let's just finish all the other parts of the document. All right, so I'm going to click down to transport destination information, and number of patients transported in this unit was one. How the patient was moved to the ambulance. Now, look, you might say, "Wow, that seems kind of anal," but actually, back in the day, before you had all these little fields and stuff like that, you had to remember to put that into your narrative. So there's a lot. So now what you're seeing here is this thing is actually collecting so much information that the amount of literacy that you need to actually write a cohesive patient care report actually is not that high anymore. I think it's great. Because trust me, people wrote all kinds of shit on here. Literacy has never been a strong suit for people engaging this anyway. And being able to write stuff, a report is actually kind of a hard it's actually kind of a hard skill to get people to do anyway. The police academies and all sorts of different types of people or agencies have a hard time training people how to write a decent report. Um, we could probably write more reports than anybody because, like, you think about it, like on a fire truck, who writes the reports there? Well, the lieutenant, whoever's riding seat, writes the reports. Everybody else is just kind of along for the ride. So on an ambulance, you could be writing all the reports. So yeah, this is a good information. So we carried her on a stretcher. Transport mode from the scene was non-emergent. All right. Um, position of transport during position of the patient during transport. We put her in a semi-Fowler's position, which is sitting up, half sitting up, like at a 45-degree angle. EMS transport method was ground ambulance. Destination transport to time was we got to pick a hospital, and I'll just pick Capital Regional Medical Center. Reason for choosing the destination, it was a patient's choice. Which, by the way, who the patient so like, how do we choose what hospital to take the patient to? We never really talked about that. Well, um, um, the the patient usually requests the facility that we're going to transport to. Typically, if you're doing 911, the you're going to have to transport to an emergency room. However, I do see the possibility that maybe you could transport to a urgent care center or something like that. I don't see why that would be a problem. Um, in fact, I don't see why you can't integrate urgent care with ambulance. You know, that seems like that would be the way to go. But anyway, I don't. It's somebody else's world. I just kind of live in it. But anyway, the hospital can be chosen. So what if we determine that the patient needed to go to a different hospital, and the patient wants to go to this capital city or capital one hospital? Well, if that's the case, then like, if we go to where she wants to go, as long as it's within a reasonable distance. So there's certain rules to, like, where you can transport patients to, like, so it starts off with you have a list of hospitals. You have supposed to have a policy that has a list of hospitals within a reasonable distance. So one, you have to start with that. So if the patient wants to go to Columbus and you're in Atlanta, then you can say, no, we're not going all the way down there. We don't do that. It has to be one of these 30 hospitals that we can take you to, and then uh, and again, if the patient says that she wants to go to XYZ hospital and the hospital's on diversion, okay, well, the patient can still says, well, I don't really care if they're on diversion or not. I just want to go to that hospital because that's where my doctor is located, and that's where you go, and that's the right way to do it. All right, so hospital capability. It's a general hospital. Okay. All right, we did hospital pre-arrival alerts. We're going to say none. But what's a hospital pre-arrival alert? Hospital pre-arrival alert is uh, a hospital pre-arrival alert is like when you call them like a trauma center. You say, "Hey, they're gonna do a trauma alert," or we talked about the stroke center. You go, "Hey, we're going to stroke alert." Those are all pre-arrival alerts. Okay, so we're making good progress here with it. It looks like we still have to finish it. Let's finish. Let's go back up here and do these times. Awesome. So our times are good. Oh, we also have to add mileage in here too. So let's put some mileage in here. It looks like we got a problem here with one of our times. Okay, so it's one of our times out of sequence. Our vital signs are out of sequence somehow. So we have to change the time of our vital sign from 8:46 to 8:59 or 8:58. All right, see how that straightened out our times? It's a problem over here. So our timeline looks good. Our mileage looks good. Is this anal enough for you guys? Again, all this was a necessary information. You had to actually kind of remember to write it in there. So uh, now I get to go in here and do our narrative. The cool part is the narrative doesn't have to be that great. So again, at my age, like a narrative was narrative writing, like if you had a serious call where maybe a person refused transport and died or something crazy happened, right? Everybody would sit down and like, hey, you know what? We probably better let Gary write this one. He writes better patient care reports than we do because this call is so serious. We respect this, and so now, I mean, look, how much risk really is there on this call? We called now. She called 911. Oh yeah. Also, what's the other thing? What do we think was wrong with her based off your index of suspicion? If you had to guess, we have a 53-year-old female with childbearing age. All right, so I'm just waiting on you. I just want to say, what do you think was wrong with the patient? It's a female. She's got abdominal pain. Female. Bingo. Ectopic pregnancy. Yeah, there you go. Now, again, what's the likelihood that you're wrong here? It's highly likely that you're wrong. Okay. So, but all right. Here's the other thing. Did we? What's our risk level? Like, what do you think is our risk level for this patient? Right. Our risk level is very low. So, how much do we really need to write? Because basically, what we did, we were called to do. The call went exactly the way you would think it would go. She called 911. We showed up, okay, and we asked her some questions, and then we put her in the ambulance and we took her to the hospital. It's very low risk. We did absolutely very little. We have very little to worry about here, assuming we didn't say anything nasty to her, like, oh, your house smells like cat piss or something like that, or or tell her that she's fat or something like along those lines, which happens a lot. Believe it or not, EMS people can be rather cruel to patients, especially when they're at their in the darkest hour. So like, I mean, if you can't choose really good words to say, just shut the fuck up. That's been my policy for since day one. Like, if you really don't know what to say or have anything good to say, then just shut up. Okay. And pretty good pro tip there. All right. So, yeah. So assuming there's very little like this. There's very little risk of this going to court or anything like that, right? So, how do we? What do we write? All right. Well, so what I like to do is, so a lot of people would sit there and write through some kind of format, like SOAP, which is what's in the curriculum, which stands for subjective, whatever the patient complains of, objective, which is what you saw, assessment, what you think was wrong with the patient, and what you did, like plan. Yeah, well, I don't disagree with that. And in fact, that actually really fits this particular call, but it doesn't fit all of the calls. So, so my problem with all these preconceived ideas about about documenting patient care, and you having to apply what you saw in a sort of a into some sort of a format that wasn't really organic to it. Well, why don't you just type what you did using the language we learned in the class? So this is the way I do it. I go scene size up, one patient, no mechanism. Okay, scene was safe. Now we could elaborate on that. We could say we responded to a uh, a well kept residential neighborhood. I mean, like I said, I've seen it all. So I mean, like, people will put all kinds of shit in there. Uh, you could put that in there. You could set the stage if you want to. It's up to you. But in this case, I'm gonna say the scene was safe. I like less is more. All right. Primary survey. The patient was alert, speaking in complete sentences, no respiratory distress noted, radial pulses. Patient met EMS on front porch. Actually, might have put ambulatory patient. And when I talk about the ambulance, I just use EMS because it's the shortest way to say ambulance crew. Okay. I kind of like to see like I kind of like this sort of the shorthand that kind of goes into a Craigslist ad. Let's just take a look at a Craigslist. All right, here's Athens, Georgia Craigslist. Let's look at Lost and Found. Boom, that's a good one. Hmm. Lost my female cat. She is older, active, and playful. Walking group. Found dog in Covington. Oh, there's a picture of him. Okay. Please spread the word so we can reunite this dog. And this is too much. Let's see. Stolen e-trike. Bam. Okay, look. Less is more. See that? There's a picture of it. I mean, I like this e-trike. It's pretty cool. Okay. Add motor. A $200 reward paid upon recovery. No questions. Awesome. He just wants his trike back. He's willing to give you 200 bucks for it. Found pearl necklace. I have a pearl necklace for the right person who wants to wear it. Oh, wait a minute. They're probably not talking about a pearl necklace. Hold up. All right. So anyway, the that's just the world of Craigslist ads. See, just keep it short and sweet and get to the point, and you'll be better off. Okay. All right. So back to this. So alert: patient was speaking in complete sentences. No respiratory distress noted. Radials. Ambulatory patient met EMS on front porch. Okay. All right, look, focus history and physical exam. So like, let's go back. What's already been said about this encounter? We already have a complete record of her focus history and physical exam. We know that we already have documented that she's complaining of abdominal pain. We already know that it's had been going on for some time. We know what medications that she takes. We know what allergies she has. We know all of this stuff already. So, um, what is there really to write here? I mean, not that much. So, we could say abdominal noted abdominal tenderness to lower quadrants. Patient was afebrile. That means not to have a fever. I would write that. And believe it or not, what I'm teaching you here is um, what I'm telling you here is extremely like I wouldn't say controversial, but a lot of people would disagree with the brevity of this. But look, if like part of your job is going to be writing patient care reports, uh, the it's actually the biggest part of your job. In fact, this is the actual output from your call. Okay, so you got to think about this as but you'll every time you have a patient encounter, every call that you have to go on, you have to go through this entire process. Okay, and yeah, to me it seems like a lot. Honestly, I really believe that a lot of this should have already been written before you even started the report. Honestly, I think there needs to be that level of support for you guys, but there really just doesn't seem to be. It sort of it ends up getting dumped in your lap. And then finally, what I would say is, I would say patient was patient transported to XYZ hospital. Actually, we already wrote all that stuff. We already know what happened to the patient. There's nothing really else to write. We already know how the patient was moved to the stretcher. So, like, what else do you need to write here? I think that's it. Okay, so look, we're at 100% validity. So I'm going to finish the incident. Okay, so what have we learned here? The patient care report provides you with an enormous amount of data. um, an opportunity. It basically can convert the entire call into data, right? So, like, why not just use that to its maximum potential and um, use that to its maximum potential and collect as much information as you possibly can. And all right, some of you guys are already done here. Very good. All right, so is anybody stuck? All right, so I've got one, two. So Novak and Brodesky, you guys are basically done. All right. So with this, all right. So that's what I need you to do. I have one more thing for you guys to do, but you can do this on your own time. So I'm going to send you guys an email. All right. So Novak and Brodesky, I'm sending you guys an email. This is the last thing I want y'all to do today, but it's probably going to be easier for you to probably easier if you just do this on your own. Okay. No problem. Yeah, that's pretty much it. So I'm sending you that. Yeah. Yeah, I'll send you yours too, Ayers. So if you're at 100%, anybody that's lagging behind, I'm going to help you out. So don't worry about that. Let me just get these guys out of here, and I'll work with you guys. All right. So um, just give me 1 second here. You're good. Awesome. Okay, so I sent emails sent to Ayers, Novak, and Bradescu. So you're good to go. Okay. Okay, cool. I'm gonna go ahead and send your email out too. All right, fantastic. And I'm just gonna work, and I'll be able to work with Schumann. Yeah, that's what we're working on. All right, I'm gonna. Okay, awesome. So Jade, I already sent you an email. Wayne, before I jump in there, let me just go ahead and send you this email real quick. So I just have it out of the way and we just bang it out. 'Cause I don't think it's not gonna help. It's not gonna take me that much time to straighten out your report. Mhm. Okay, Wayne, I'm gonna log in as you real quick. Oh, okay, you're getting there. You gotta add crew members. This time it wants two. Patient is not, the name is not, is applicable. Okay, hold on, Jay. Let me finish his up, and I'll come back and look at yours. Okay. All right. I think I got you caught up, Wayne. Do you want to bang out? You want to write a narrative, or you want me to do it? Here, I'll just write it for you. All right, there you go, Wayne. You're all set. Oh, you figured it out. Okay, you're good. All right, looks like you figured it out, Jade. All right, Jade. Very good. All right, man. So looks like you're dismissed. All right, so we'll be in touch.